Hello, good afternoon, morning for some folks. I'm Vaughn Edelson, Programs Manager at Genetic Alliance. I'd like to welcome you to today's webinar, Family History, Prenatal Care, and Novel Health Information Technology, a collaborative risk assessment and educational tool for health professionals and the public. The project that we'll be talking about today is a collaboration among the National Coalition for Health Professional Education and Genetics, March of Dimes, Partners Healthcare, the Health Resources and Services Administration, and Genetic Alliance. We're developing a family history tool for prenatal providers and patients. Just a couple reminders before we get started. The session is being recorded, and it will be ready for viewing and downloading next week in the resource repository, which is resourcerepository.org. All participants for today will be muted, so please use the question function on the webinar panel to submit all questions. That should be on the right side of your screen, and at any time during today's presentation you can type in questions and I will ask them to the presenters. So without further ado, our presenters today are Emily Edelman, Project Director at NCHPEG, the National Coalition for Health Professional Education and Genetics, Bruce Lynn, Manager of Public Health Initiatives at March of Dimes, and Emily and Bruce are the co-project directors for this initiative. We also have with us Brian Drohan, Application Developer at Partners Healthcare. And so now, I'll turn it over to Emily.
Thanks, Vaughn. Hello, everyone. I'm very pleased to speak with you today about this collaborative project, Family History for Prenatal Providers. As Vaughn mentioned, this is a collaborative project. The partners include NCHPEG, Genetic Alliance, March of Dimes, Partners Healthcare, and of course HRSA, our funding agency. Today I'm going to talk with you about, Brian Drohan and I are going to talk with you with some background information about this project. We'll review recent progress, talk about where we're going next, and then Bruce will take over and do a demonstration of this tool for you all before we open up for questions and discussion. So this is a 3-year project, and we are a little bit less than halfway through. We're in the early part of year 2 of this project. The goal of this project is to develop, implement, and evaluate an electronic family history and genetic screening tool for primary care prenatal providers. This tool collects medical and family history information from the patient, provides clinical decision support and education for the provider, as well as education for the patient at the point of care. The overall goal for this project is to improve identification of women and babies who are at risk for genetic disease. We are using the tool as the centerpiece for provider education and as a vehicle to disseminate relevant patient education materials. We hope that this tool will save time for the clinician by providing just-in-time recommendations and support for ordering genetic testing and management of genetic risk factors. We hope that it streamlines the intake process in clinic, reduces the clinician's concern and risk for liability, and of course to empower and educate the prenatal patients who are engaging with their providers at this first prenatal encounter. This figure demonstrates the data flow for this project in a simplified version, of course. Our approach is to use the female patient's first prenatal visit as an opportunity for intervention for both the patient and provider. So the patient completes the questionnaire in the waiting room on the tablet PC or on a computer, and that information immediately goes into the tool's database and provides risk assessment and clinical decision support to the clinician at the point of care. It also generates educational materials for the patient and provider targeted to the patient's risk at that point of care. And as a future phase of this project, you can see down in the left corner we have dashed lines for the electronic health record integration. We will identify a plan for how to integrate this tool and the data that it's collecting, as well as risk assessment and family history information into the electronic health record. So what is on this tool? Really, it's what you would expect to be asked, or the information you would expect it to provide on any type of intake form at a doctor's office when you're presenting for medical care. We collect general information about patient demographics, information about patient medical history, pregnancy history. One thing that's a little bit different is that we are asking questions about newborn screening awareness and providing a little bit of education within the tool and then in the follow-up materials. We ask information about the father of the pregnancy, and we use the abbreviation FOP or FOB for father of the pregnancy or father of the baby in our abbreviations here. And then we collect information about family history on both sides of the family. And this family history information we're collecting is targeted to a select list of both common and single gene disorders that can affect the woman, the health of the woman and the health of the fetus during pregnancy. This list was carefully crafted, as I'll discuss in a moment, and it was based on ACOG, ACMG, and other professional society recommendations for what prenatal providers should be screening for in the prenatal period. We also ask questions about genetic testing in the patient, father, the pregnancy, or family, so that the provider can follow up on that as appropriate. One of the most important steps in this process early on was to identify what conditions to include on the tool. To accomplish this, we performed a detailed review of existing prenatal intake forms, which ends up being very heavily based on the ACOG prenatal intake form that many practices use. We performed a literature review and reviewed the professional society guidelines, again, focusing on ACOG, ACMG, and other professional societies that provide guidance in this area. And we consulted with expert clinicians and geneticists for additional guidance when needed. As I said earlier, in summary, this is essentially what a person is asked at their average visit, with perhaps more emphasis on family history. And in those family history questions, there may be a few unfamiliar terms and questions. So we've created some support for the patient completing this tool with definitions and explanations, and Bruce will show you that later on when we do the demonstration. We do have an evaluation plan in place for those conditions and algorithms on the tool that will involve expert external review. So I'm going to turn it over to Brian, who's going to talk to us about the clinical decision support approach for this project.
Thanks, Emily. Good afternoon, everyone. So what we mean by clinical decision support, I tend to think, is helping clinicians make the decisions and plans that they already expect to do, but have that information be reaffirmed, that decision-making process be reaffirmed by the electronic tools that they have available. So in specific, in this project, we talk about responding with triggers and considerations for future actions. So basically, the idea is that we combine standards of care and structured patient data. And what I mean by structured patient data is just any patient-reported information that you can actually store in a computer and then query. And we combine those with algorithms and guidelines to provide recommendations, in this case via reports as a primary mechanism. But the future really, I think, is in visualizations that help the clinicians understand and quickly identify the information that they have in front of them. Emily?
Thank you. That was excellent. So as I said, we are into year 2 of this project, and a lot has happened in year 1 and the beginning of year 2. We had our first advisory committee meeting last year around this time, and that was very helpful. We have a great panel of advisors who are helping us with this project in various aspects. Through the hard work of Brian, his colleagues at Partners Healthcare, including John Sharko and, of course, Dr. Kevin Hughes, we now have a beta version of this tool available, and you're going to see that in a moment. It includes this version includes the tablet PC-based pregnancy and family history questionnaire that the patient sees, and it includes the clinical decision support algorithms that Brian was just talking about, and the clinician or clinical report elements that the provider sees for decision support. Our formative evaluation is underway. Dr. Teresa Doxum is our external evaluator for this project, and she designed our formative evaluation, which includes pilot testing the tool with 15 women recruited from the general public, and pilot testing the tool and clinical decision support with 20 prenatal providers from different disciplines. And when I say different disciplines, that includes general obstetricians, nurse midwives, family medicine physicians, nurse practitioners, and other individuals who provide that primary care, prenatal care. We're also, as I'll talk about in a moment, we're looking at potential clinical sites to implement this tool. So for those sites who've already expressed interest, we're also piloting the tool with some of their providers to see how this would work in their clinical setting. These results should be available in mid-November for our second advisory committee meeting. So of course, looking ahead in the near future, we need to complete our formative evaluation and the other elements of evaluation that we're looking at. We're really excited and gearing up for presenting all of this work to our advisory committee, which will, that meeting will happen on November 15th and 16th next month. We are planning for a clinical implementation using this tool in clinic with patients and their providers in March of 2011. And we're still in conversations with clinical sites, but we're looking at sites right now in Maine, Maryland, and California. And a recent addition to our project that we're all excited about is a partnership with Holly Tutko, who's a public health provider from New Hampshire. And Holly is working with us to develop an external provider education component that talks about the value of family history in prenatal care that people can use. It complements the tool, but it's external, and that will be posted for individuals who are interested to use for education. And I think that is it for me. So now we're turning it over to Bruce for demonstration.
Thanks, Emily. I didn't know if anyone had questions so far, but I think we're taking them at the end. So right now, if everyone sees on the screen, this is a selection of the appointments that the medical staff or the front desk would see. I'm going to select our appointment, and what happened is I'm going to then hand off this tool. We're going to use it in clinics on a tablet PC, but it could certainly be used on a kiosk, or if there happens to be a workstation that was private. So at this point, I am now the role of a prenatal patient. Again, like Emily mentioned, this is my first visit, and this is just to confirm. And from here on out, I'm going to go through the screens pretty quickly, and I'm going to try to skip a lot of questions. And I'm actually using a computer that has a lot of things loaded on it, and this tool is not actually as slow as it's loading up right now. What I have, that was the initial welcome screen, and one of the things that we thought we wanted to ask about in our evaluation was these videos. This is an example that was created by Genetic Alliance, led the effort, and it's meant to give the patient some context as they're developing, as they're finishing this questionnaire, as they're, beginning this questionnaire, and just to give them some assurances. And you're seeing a little bit of that video now. We have only one video. We're thinking about putting others throughout the tool, and we just put this one in. We're asking about people's responses in the evaluation. So the next couple screens, as they appear, are basically demographic screens that are found in patient intake forms. And for whatever reason, it's going a little slower than when I was trying out this morning. Now it's fired up. So we do ask about questions like adoption. We do ask about basic ethnicity. There are questions about ancestry as well. And we get into sections about some of the activities, risk factors, alcohol consumption. We get into medical history. You'll notice one of the items here, these blue icons, these are meant to be info buttons, and that gives an opportunity, if the patient is unfamiliar with the term, to click on that and to read more about it. And you also notice on the top there, there's a progress bar as the questionnaire moves along. And throughout this tool, there are a lot of branching screens, depending on the selection the patient makes. It will lead to a different series of questions. We are, as we're testing this, we're finding that the pilot group is actually able to go through this fairly quickly, 15 to 20 minutes. We had thought it might take half an hour, but we're glad to see that it's 15 to 20. And again, there are a lot of pregnancy-related questions based on this first visit. So I'm just, again, going through this very quickly with so we do have these info buttons throughout. And this is the section on family history. And you'll see the screens that allow us to link the condition, and it could be a series of conditions, to the family member. And I'm just going to input some basic data. And for people who are interested, we do have a list of all the questions that are in the tool, this version of the tool, and some of the branching questions as well. We ask the same demographic questions of the father of the pregnancy, including their race and ancestry information. And there is an opportunity, because we do not ask for every rare condition that may be found on other intake forms, there is an opportunity here where there is free text, and try to limit free text. As Brian mentioned, it's better to have structured data, but we want to give that opportunity for anyone to write something in that's not listed in the tool. Emily mentioned the genetic testing question. And we do ask about consanguinity. There is another opportunity here to, if they decide to put their email address in there. And they, again, at the end, have an opportunity to say if there's concern about anything else. And this is another rare instances of free text. So then they're asked to return the tablet to the medical assistant, and at this point, the tool is going to begin its risk assessment. And this piece right here is built by Dr. Hughes and Dr. Drohan. This is related to a cancer risk assessment, and it's the one area where, because they've already used this in different settings, we have quantitative risk assessment, but everything else in the rest of this tool is very qualitative in nature. So you'll see this as the report is being generated. So I know I went through that very quickly, and now my computer is going to switch over to the main screen. And usually we would pause here to see if there's any questions, but I know that we're saving those till the very end. And something to keep in mind is that what we're trying to do in the 3 years is to demonstrate that we can take this opportunity, the snapshot in time of the very first prenatal visit, and see if it's an opportunity for intervention based on the decision support we have in the that is manifested through this provider report. And so once the tablet has been returned, what's happening is that the tool is going to be generating a provider report through Microsoft Word. And Emily mentioned that we, in the future, are making plans to integrate some of this data into an electronic health record, but for this 3-year piece, our goal right now would be if a clinical site had an existing electronic health record, our workaround is that the report could be imported as either a PDF file or as a Word document on its own. So what you're seeing here is just the tool creating this report. At the very top is the considerations that the clinical decision support is based on, and the rest is just filling out this report with the data. A lot of this obviously is not reported because I skipped through it very quickly. But what I'll show you here is just an example of an existing report. Of what that would look like. So again, at the very top, it's just a pregnancy information, and then these are the considerations that are generated by the decision support. And we do have one for patients and some for father of the pregnancy. And everything else is, you saw it generated live, and this is just what it looks like in PDF form. So we made this purposely a quick talk, because I know there might be different aspects of the tool and the project that people are interested in, and we want to have a lot of opportunity for discussion. So Vaughn, I think the group is ready for discussion.
Great. Thank you, Bruce, and Emily and Brian as well. I'd like to remind our participants that you can submit your questions through the question function on the webinar part of the screen that should be on the right-hand side. While some more people are typing in, we have had a couple. Bruce, actually from me, you had mentioned that people can find the list of, we have available the list of questions and the branching logic. So if people were interested in that, where could they access it?
They can email me, any one of the partners. We can provide them a PDF of that.
Great. So I think then people, if they were interested, could just email either Genetic Alliance to get, and we can pass that on to Bruce. Great. We had a couple questions about the educational resources that are included. The first one was about the newborn screening information. If this is for the first prenatal visit, what type of newborn screening information is being given to patients?
Bruce, do you want me to address that?
Sure.
So I think these slides got skimmed over because we didn't have time to really dwell on them. But we recognize that the first prenatal visit is a challenging time to talk about newborn screening awareness, especially if it's someone's first pregnancy. There's quite a large possibility that they aren't very aware about newborn screening. But we do have a question in the tool right now that says, has anyone talked to you about newborn screening, or have you heard about newborn screening in the past? And there's an info button about that has some information about what newborn screening is. We also have a question when talking about family history, and particularly if a woman has had previous children, we ask if anyone in the family or for previous children had an abnormal newborn screen. And again, we provide some education in the tool about what does it mean for someone to have an abnormal newborn screen. And then in the follow-up materials, when this report is generated on your screen, you can see right now, this is a fact sheet for the provider. It's kind of an appendix, and this is a fact sheet about hemoglobinopathies, because this woman was, based on her personal and family history, was triggered to have an increased risk for a thalassemia. So this is the targeted fact sheet that the provider is receiving about hemoglobinopathies and how to test for that. But we're also going to have complementary little fact sheets for patients surrounding these conditions. So there would be a patient-friendly fact sheet about thalassemia that would be included as well. And in that patient stack of fact sheets that are generated, we anticipate having some information about newborn screening available as well.
Thank you. The next question is, will the breast and colorectal cancer risk results be part of the demonstration projects?
Bruce, can you go back up to the part on the screen where we include those risk probabilities? There. So that's a great question, and it's a challenging one. ACOG has recommended that prenatal providers screen for and provide risk assessment and communication of that risk to women about, at a minimum, the risk for hereditary breast and ovarian cancer syndrome, or the BRCA gene. Another probably similarly prevalent condition would be Lynch syndrome, or hereditary non-polyposis colorectal cancer. So we feel that it's important information for providers to talk to their patients about, and we've heard from our prenatal colleagues that they certainly could use some help with assessing risk for those cancer conditions. However, we also have heard from our prenatal colleagues that the first prenatal visit probably isn't the appropriate time to be getting into a detailed conversation about someone's cancer risk, and we appreciate that. So we're still trying to find the right balance about how to provide this information that we think will be helpful to providers, but to provide it in a way that's meaningful and useful and not overly concerning at the first prenatal visit. But right now the plan is to provide this information in some type of table like what you see now up on the screen.
I'll add to that, based on what you're seeing right now, the risk calculation, for example, BRCA mutation. One of our current algorithms we're discussing with our experts is we're thinking about tripping that. If it's above 5%, it would come up at the top of the report as a decision support trigger. So again, this is one of the issues that we will be discussing with our advisory board and also the experts that are evaluating our algorithms.
And if I might jump in for a word about algorithms, in terms of the actual computation of the HNPCC risk models, what we have available to us is MMR Pro, the peer to BRCA Pro from the Bayes-Mendel community, as well as the PREM model from Dana-Farber. So those are the two algorithms that are already available to us with the data collected in this format.
Thank you all for those answers. A couple more questions. The next one is, I didn't see evidence that half-siblings are taken into account. Is this simply seen as too complicated for the patient when filling out the history, or maybe not necessary for a general overall assessment?
That's another great question, and I'm laughing because, yes, it is complicated, as Brian can attest. We are collecting information about half-siblings, in fact, and if someone identifies they do have a family history of, for example, mental retardation, one of the branching screens that Bruce mentioned is that there'll then be a screen that says who in your family has mental retardation, and it will list sisters, you can identify how many, brothers, you can identify how many, and then both half-sisters and half-brothers. So we're still trying to figure out some of those more complicated elements of pedigree structure and making sure that it's accurate on the pedigree and that we get that information correct without having to ask patients a billion and one questions about how people in the family are related to them. But we do think that's important, and we are working on including that.
That's right. And if I might just add a detail that half-sibs and are challenging in their own right. The real difficult one, I think, is the nieces and nephews, because just from the survey, you don't necessarily place the nieces and nephews underneath the correct brother or sister without additional follow-up questions. And that, I think, is the line that most people feel is too difficult to get without a conversation with the individual.
Thanks. Next we have, what sort of evaluation has been done to compare self-report on the tablet to other means of intake, and how do accuracy and scope compare?
That's another great question. And that type of validation is very important. So we're doing informal testing of the tool and debugging, of course, to make sure that the data that someone's inputting into the tool from a pseudo-patient situation comes out appropriately on the back end. So that's continuous, and we are continuing to make those updates. But I think that the question is getting at the larger question of how do you know that the risk assessment provided by the tool and that the pedigree information provided by the tool is accurate or appropriately similar to that which someone might report that information to a provider. So as part of our pilot testing with members of the general public, we are doing in that model, the women who have been recruited and agreed to participate in this pilot study meet with our interviewers, one of which is Ms. Vaughn Edelson, to go through a structured interview and observation using the tool. Those women enter their personal family history information into the tool, and the report is generated as well as a pedigree. Anywhere from a couple days to a few weeks afterwards, I'm calling them for an independent family history re-review. So without having looked at the pedigree that the tool is generating, I'm collecting their family history information a second time, and we'll be comparing the pedigree structure, so the number of individuals, the types of individuals, and how they're related to the proband, as well as the conditions that are assigned, and the risk assessments that the tool generates compared to what a genetic counselor calculates to see if these things are concordant. Now, it's a small n, and we'd like to do a larger scale evaluation as a next step of this project. Bruce, Brian, do you guys have anything to add to that?
I think that's a great answer, and it represents the real step forward that this project has taken the technology. Our experience at Partners Healthcare, and now just to be clear, I'm speaking just for our group here at Partners, that have been developing tools like this for hereditary breast cancer screening. We have traditionally brought the system into play as patient care, and I think that it's appropriate because the traditional collection and analysis of the information, I think, is a low bar, and the computer has never really lived up to its potential here. And we haven't studied its effectiveness as a tool because patient care has always been our early focus.
Thanks. We had one more question that is asking if you could go into a little more detail about how you're selecting the clinical sites.
Sure, I'll start with that and ask Bruce to jump in as well. We have a set of criteria that we've defined for how we're selecting clinical sites. So if anyone is, and that process is still open. We're having active conversations with people, but if there are folks on the line who are interested in hearing more about what are the requirements and benefits to being a clinical site, please contact me or Bruce, and we'll be happy to talk with you more about that. But some of the things we're looking at are sites that have a nice breadth, a large number and breadth of prenatal providers who would be willing to test the tool. We want to make sure that the sites are serving different types of patients and different patient populations, including underserved patient populations. The sites need to be able to work with us to get this tool set up on the IT side, and Brian will be very involved in providing support there and work with us to implement this in their practice, and that's where Bruce and I will be very involved, and also collaborate with us on the evaluation piece. So there's a lot of opportunities for partnership and collaboration here, and those are just a few of the criteria that we're looking at or the issues that we're looking at when we're talking about partnerships with sites.
I think I'll add to what Emily said was that a champion within the clinic, someone who really wants to test out this tool, who really thinks this is a good idea. And I think that's also a critical piece. We've spent, I guess this is a 3-year project. We spent the first year doing the validation, testing, programming, developing the tool, and there is some funds. We're hoping to get more, but there's limited funds for the clinical sites, and we're hoping that, that if we have that champion, that kind of will help us ease into some sites. And I'll also say, as a piece of software, this is federally funded. It's a cooperative agreement with HRSA, and that when we do launch in March 2011, the software still will be available to any site that would want to use this.
Thank you, Bruce, for touching on that, because we had a follow-up question around what were there any barriers encountered so far in looking at clinical sites in terms of their adoption of this. We actually had another follow-up to the previous question about evaluation, just a comment saying, thank you, it sounds excellent, but that issues with low literacy are a concern. I don't know if anyone wants to elaborate on that, or just agree.
Low literacy is definitely a concern.
Yeah.
I'll just say that we have plans right now to take a look at all the questions on the screen and all the info buttons and reevaluate those and assess them. And we have to see if we can fit that in our budget. What we have done, some of these questions have been used in different tools, some of the demographic questions or others not related to pregnancy, but that was gone through the Microsoft version of trying to assess the literacy level of questions. We try to keep it very simple, but it's definitely an issue that we want to address.
I completely agree. Thank you, Bruce. And just very quickly, I think there are barriers to adoption here, and they're real. You know, certainly time. One of our goals of this tool is to save time for the clinician and create a standard process for how people can collect and act on genetic and family history information. But to participate in testing, anytime you're enacting a new system in a medical setting, anytime you're changing infrastructure, it's going to take there's going to be a learning curve, and it's going to take some time, and it's going to take some staff resources. So those are barriers in place, and also, of course, support for equipment. We are seeking additional funds to provide more support for our clinical sites, but that's a concern. And I think just, again, going back to this idea of adopting change, and it's why, as Bruce said, it's so important to have at least one clinician with some sway in an institution who's really excited about this and really wants to try implementing it in clinic and can rally the support of his or her colleagues.
Thank you all. We don't have any other questions, so for participants, if you have any last questions, please submit them now. But for our panelists, I'd like to thank all three of you, and I guess if you have any last words or comments, please feel free to share those.
This is Emily. Thanks, Vaughn, and thanks to everyone at Genetic Alliance for giving us this opportunity, of course. I just wanted to acknowledge the other partners. We have an almost complete representation of all of our partners on this call, but of course, there are other folks who are critical to this effort who aren't on the call, and they include Joan Scott from NCPEG, Siobhan Dolan from March of Dimes, James O'Leary from Genetic Alliance, John Sharko and Kevin Hughes from Harvard Partners or Partners Healthcare, and of course our HRSA colleagues, Michelle Perrier and Elena Harris, who just joined the project staff.
Thanks, Emily, and again, thank you all for sharing our project. For participants on the line, we will definitely be holding future webinars as this project progresses and we get more into the evaluation and implementation to keep everyone up to date. So as I said at the beginning of the call, the session was recorded, and it'll be available for viewing and downloading probably by mid-next week. So if you know anyone who wanted to join us but was unable to today, you can feel free to pass that along. And there are lots of webinars to look forward to. We have a full schedule this month, webinars every Wednesday from noon to 1 p.m. Next week we'll be featuring the Genetic Alliance social media strategy and our tips and tricks. So please continue to join us, and thank you again.